are now live with Carlos Lluminguano in Yemen.
Good morning. Thank you very much for your invitation for this conference. Today we will speak about topics about spinal trauma in elderly. We will speak about the management of vertebral body compression fractures in the elderly patients. Without any spinal the spinal trauma management, we can have a clinical assessment about what kind of neurological deficits or neurological change have the patient. And we speak about the diagnosis, what's about the clinical evaluation and radiologic assessment, such as needed to do an X-ray, what was the paper in a conventional X-ray, functional X-ray, and some kind of specific rays. And what's about the spine CT, the paper with a three-dimensional CT and sagittal or coronal view. What's about the reading of the spine MRI? And we can analyze about the treatment of this change in the vertebral body. If we need a conservative treatment, such as using orthosis, or maybe the patient just need a rehabilitation, or we have to do a surgical treatment. It's dependent, it's urgent, deferred, or programmable surgical treatment. We can do a follow-up patient after the acute stage treatment, such as maybe he needs monitoring and a control for the patient at several times, or need to continue with the rehabilitation. What about the classification of the fracture? We can use the classification for our spine, which system analyze about the anterior column and posterior column. We can have which kind or which types of fracture we have: type A, type B, type C, and each of them with the management specifically. For the neurological evaluation, we can use a Baccaro scale or maybe a Frankel scales. In the spinal trauma, we can have use a macro classification. The type of fractures which important is an axial compression, and we can have A1, A2, A3 types of fracture, but in all times they are affected just the anterior column of the vertebra. A type B fracture essentially is by the placement in a sagittal plane. In these types of fractures, we can have an effect of the anterior and posterior column of the vertebra. In a type C, we can have a displacement of the in the coronal plane with a serious affecting of the anterior, medial, and posterior column of the vertebra. In a clinical assessment, the most commonly used scale at the international level for assessing the extent of or completeness of the spinal cord injury is the ACE. It's an American Spinal Injury Association standards for neurological classification. This scale classifies spinal cord injury according to the 5 grades determined by the absence or presence of motor and sensory function. With the Frankel classification, we can have a Frankel A, where it's an absence of motor and sensory function. The type V, there is a sensation present, but completely absent of motor function. In a C type, sensation is present, motor function is present, but it's not functional. It's a grade of paralysis 2 per 3 per 5. Type D, the sensation percent, motor function at present, and may be useful because this is in a grade 4 per 5. And type E of Frankel, it's a normal function, motor and sensory function. In this case, we can see the distribution of the motor neurologic innervation and the sensory function too. For this conference, the important thing is I speak about the treatment or management of fractures in the elderly patients. Fracture of the vertebral body due to wedding or compression in elderly patients are frequent and affect approximately 20–40% of the population. Usually affect the thoracic and lumbar region and not always associated with neurological deficits. The relative risk of fracture after an initial fracture is about 4.4 to 5.4. After a vertebral fracture, the risk of a new fracture per year is approximately 19.2%, and the cumulative incidence in 10 years is approximately 70%. In these pictures, you can see the normal structure of bone and down the osteoporotic bone, with a important diminution of the mineralization of the vertebral bone. We can have different causes such as osteoporosis, maybe a pathological fracture, maybe tumor, and just a traumatic fracture, non-osteoporotic, type E and type B of Mager. What's the objective? It is primordial to avoid a neurological injury in those patients who remain neurologically intact after trauma, using techniques of grit, release, or aggressiveness. The solution should be pain relief, restoring anatomy, early diagnosis and treatment, or an adequate aid for geriatric patients given the frequent fragility of their condition and the presence of multipathology. What about the symptomatology? A vertebral fracture produces localized edema and there is often pain. In the spine, edema and lack of alignment can irritate the adjacent tissue and nerve elements. A damaged vertebra is sufficient to alter the alignment of the spine and the distribution of the weight in it, which could cause other fractures. How to assess these kinds of fractures? We can do it on a correct physical examination. We evaluate the pain. We can use for this a brain pain inventory scale or visual analogy scale for the evaluation. What's about the neurological symptoms? Sensory function, motor function, sphincter function. We can use a Franklin scale to do a correct neurological deficits examination. In imaging or radiological imaging studies, we can use a simple X-ray to define the stability of the vertebra. We can do in a CT scan. We now must determine if the presence or not a bone fragment. What about an adjacent segment? Maybe we can use a spine MRI, a T1, T2, or STIR sequence. At this point, we can discuss about if this type of studies is urgent or maybe deferred for any time. We can do in a bone scintigraphy to determine if the patient had or not osteoporosis. What about the treatment? The best results are obtained as soon as a fracture is treated. Kyphosis, deformity, and progressive bone weakness increase the risk of further fractures. We can do it on a conservative treatment, open surgical treatment, or vertebral reinforcement techniques. A conservative treatment is what's about that? Maybe the patient needs a bed rest, but we would increase the bone loss. We can use different analgesics such as narcotic analgesics could fail. And what about the adverse effects for H drugs? Or we can use anorthosis. They may do it at a long-term functional improvement. Or maybe we need to do a surgical treatment when there is a neurological deficit. If we need to decompress neural structures and provide stability to the fractured vertebra. And what is the situation in different cases in elderly patients which frequently had an osteoporosis? What about the results in this kind of patients? Or maybe you can use a vertebral reinforcement techniques such as a vertebroplasty described by Dermot and Galibert in 1986, or do it on a kyphoplasty described by Riley in 1998. And so we can speak about the needing or kyphoplasty or vertebroplasty to do some situation. We must know that kyphoplasty or vertebroplasty techniques, it's a minimal invasive procedure that can repair the wedging or compression vertebral fracture. Both the treatment had results are specific to each patient. Early and effective treatment can reduce the consequence of spinal fractures, especially those associated with other treatments such as prolonged bed rest or the use of H analgesics. What's about the benefits of this kind of techniques? It restores the height of the vertebral body. It restores proper alignment of the spine, significant and lasting decrease in back pain, significant and lasting improvement of mobility, significant and lasting improvement of the quality of life for the patient, significant improvements in activities of daily life, decrease in the number of days and months that the patient remains in bed due to back pain. And the important thing that's a significant and lasting decrease in the number of days and months that the pain interferes with the daily activities, such as walking, hobbies, or work for the patient. Yeah, we have a kyphoplasty techniques, and we can do it all kinds of solutions for different fractures in the patient. But all the techniques, or all the surgery techniques, maybe open, maybe percutant, maybe minimal invasive therapies, had different risks. The frequency of complications in kyphoplasty or vertebrates is very low. Maybe a serious adverse events can occur, some of which can be fatal, like a heart attack, cardiac arrest, stroke, or embolism. And maybe other complications such as infection, cement leakage, which can affect the surrounding tissue, or spinal cord compression, or nerve elements compression. The indications for these kinds or techniques are in osteoporotic fractures, in pathological fractures, where actual vertebral pain due to a pathological compression fractures, such as tumor, non-pathological fractures, pure traumatic. If we have the following requirements: non-osteoporotic fractures types A and B of Magel, posterior large ligament intact, early intervention in the first 7 days after fracture, no signs of infection. It may be ideal in multiple myeloma, where bone quality limits surgical options, limited in patients with neurological deficit, and or with involvement of the epidural space. It can be combined with radiosurgery in the treatment of vertebral pain by pathological vertebral collapse. What about the contraindications? Absolute contraindication for kyphoplasty or vertebroplasty are important involvement of the medullary canal by epidural tumor, bone fragment, or discus, impossibility to determine the painful segment of or when the patient is very symptomatic, inoperability, if the patient has some medical problems that is absolutely contraindicated to do and some kinds of anesthesiology techniques. And the relative contraindications are deformity of the vertebral body, such as flat vertebra, rupture of the posterior wall of the vertebral body. I will show some cases that do it. For example, the first clinical case, we have a 74 years old patient, pathological antecedents as diabetes. She had a severe and incapacitated dorsal lumbar pain for months of evolution. At the physical examination, no health paralysis, maintained osteotendinous reflexes, antalgic gait, and posture. What kind of studies we are doing? X-rays, MRI. Well, the diagnosis was the fracture of the 12 thoracic vertebra, lumbar 1 and lumbar 2 vertebral body fracture. We do it at a percutant kyphoplasty, and the patient after 3 days was discharged to home. In the second clinical case, an 84 years old patient, pathological antecedents such as arterial hypertension, dementia, and the symptoms about intense and incapacitating high lumbar pain of months of evolution. At physical examination, limited activities of daily living, wheelchair bound, little movement, decreased osteotendinous reflex, no pyramidalism. We do in this case again X-ray, MRI studies, and we determined the fracture of L1 lumbar 1. We treated with kyphoplasty. After 2 days, the patient was discharged to the home. Third case is a 76 years old patient with arterial hypertension. The symptoms was about severe and invalidating high back pain. Does not improve to conservative treatment. In a physical examination, no paralysis, maintained osteotendinous reflexes, no pyramidalism, antalgic march and posture. Studies were doing and X-ray, MRI, percutant, or kyphoplasty. In this picture, you can see 3 months after surgery. After 2 days, the patient had marked relief of the pain. After 2 days, they were discharged to the home. In the last cases, as an 83 years old patient with benign prostate hypertrophy, splenomegaly, and lymphoproliferative syndrome. After fall, the patient had a severe dorsal lumbar pain, which does not improve to any treatments. And a physical examination, for example, no, they have no paralysis, decreased osteotendinous reflex, no pyramidal disc, march and posture limited, almost entery. I have do it on a CT, on a simple X-ray, CT, MRI, and the patient had a fracture of vertebral body 12, thoracic 12, lumbar 1, 2, and 3. We are doing a kyphoplasty of thoracic 12, lumbar 1, lumbar 2, and lumbar 3. The patient had a marked pain relief, and they have a marked improve of their gait, and they have discharged from the hospital after 4 days of treatment. So, and a kyphoplasty, a vertebroplasty, we can do it with some kinds of material, like a kypho with cement, the Spain check, when some kinds of metallic prosthesis, or with silicone. The silicone is used generally in young patients. What about drugs that they will be needed in patients? Calcium, vitamin D, strontium, ranelate, teriparatide, hydronate, such should be some kinds of pharmacological treatments parallel or after an kyphoplasty. So this is the management of some kinds of fractures in patients, in elderly patients, where it's frequent the presence of osteoporotic change. So thank you very much for your attention.
Thank you so much, Mr. Carlos. Actually, we can open the session for discussion. If anybody has any questions.
What about the type C McGreal fracture in osteoporotic patient? And what other modalities of treatment other than vertebroplasty and kyphoplasty? What the other rescue procedures?
Thank you very much. Thank you very much for the question. During the conference, I said clearly that kyphoplasty or vertebroplasty we use just in type 1A, 1A2, or maybe A3 fractures, osteoporotic fracture in the elderly, or maybe in marker R on B. But in the C type of fractures, when we have an effect in the anterior, medial, and posterior column of the vertebra, when where the posterior large ligament is disrupted, where the posterior wall of the vertebral body is disrupted, these kinds of techniques we cannot use, because this the cement that we are using for these kinds of techniques may be leakage and maybe compress the medullary elements in the spinal canal. In these kinds of osteoporotic fractures type C, maybe the important thing is to have an orthosis alignment, and maybe do it or adjuvant it with some kinds of pharmacologic treatment, such as a forsteo, such a protelos, that will be help in the calcification. But because it's maybe difficult to do an open surgery treatment, because in osteoporotic bones, it will be not a good result.
Okay, thank you so much.